Hi, everybody. So we're just going to get started. My name's Janelle. I'm one of the organizers of Evening Rounds. I'm just going to give you a bit of a background to Evening Rounds itself and some housekeeping things, and then I'll pass it on to the presenters. So for those of you who are new, Evening Rounds is the informal group, the in-person gathering of the Healthcare Social Media Canada Twitter community that sprung out from the East Coast. So now we've grown into a monthly speaker series that provides information, inspiration, and connections around health communications in our province. Evening Rounds is really a community. It's a chance to connect face-to-face with our peers who are doing really great work, and for people, sometimes you just can't talk to often. It's a chance to swap stories and share ideas on a regular basis. So that's what Evening Rounds is. Just for some general housekeeping items for today, our hashtag is eRounds, and you can also, of course, hashtag the HCSMCA. We have Wi-Fi in the room, so it's called Evening Rounds. Hopefully all of you guys are already connected on it. We're also videotaping this session, and it will be on YouTube, so that's why there's a camera in the back, and there's also a camera here that shows you guys. And that will be on YouTube and our website later on. So one last thing for the microphones in front of you. This is an interactive session, so there's a lot of back and forth between the speakers and the audience. So if you could press the button on your microphones, that will turn it on. It'll show red, and then you'll be mic'd, and then you can speak, and then turn it off after. We'd like to thank our good friends and presenting partners, Providence Healthcare, for giving us the room. Very pretty. And finally, I'm happy to introduce our moderator for the evening, Daniel. He's the communications manager and communications manager of education at the Faculty of Medicine at UBC, and our fellow organizer for Evening Rounds. So thanks.
Well, I would like to thank everyone for coming. I was assigned the task to come up with an event for April some months ago, and I knew at the time that the thing most dear to me in what I do is really looking at how we use social media in education. I will say that before I took a role doing public relations and communications, I did teach in the university systems. I taught English and creative writing and journalism before I moved to Canada. And in those years, it was roughly between 2000 and 2005, we were seeing more and more technologies come into the classroom, even in a sort of basic setting, but the social media phenomenon hadn't quite really hit and change things like it has today, where we're seeing things like Coursera and that are really opening the ideas of what education can be online, and how the university responds to technologies and to the shift in what people expect from information and how they use it and how they learn. So I thought about a couple of people who I've encountered over my years in the Faculty of Medicine who I think do interesting things related to social media and medical education, or the education of health professionals. So tonight's speakers, I have with us Dean Giustini, who is the biomedical branch librarian located at UBC's Biomedical Branch Library, which is in the Diamond Healthcare Center, there on 12th and Oak, where I am. He teaches information skills to medical students and builds research capacity for systematic reviews with medical residents and faculty. He also teaches for UBC's iSchool courses on health information and social media. He's the incoming public relations director on Canadian Health Librarians Association, and he maintains the HL Wiki International, a health wiki with over 900 encyclopedic entries on health-related information technologies. I also have Dr. Jason Ford here with us, who is the head of the Division of Hematopathology at BC Children's Hospital. He's the block chair for blood and lymphatics in the second year of the UBC MD curriculum. So in the second year, MD students sort of rotate through a set of courses. So, and nationally, he is the chair of the education group for Canadian Association of Pathologists, and also the chair of continuing professional development for the CAP. And I would also add that he's one of the the students always find he's one of the best professors, best teachers in the program. I think there are several awards that back that up. I would like to just start briefly by talking a little bit about the topic, and then I'm going to hand it over to the two speakers. And tonight's session will be a little bit different than in the past. It's sort of a loose meditation on social media and the role of training health professionals. We're going to look at what Dr. Ford currently does, and we're going to hear from Dean about what are some of the issues in terms of teaching and access to information and privacy. Then we thought we would like to have a discussion and a conversation. I certainly have some questions, and I hope that all of you have questions too, and hopefully back and forth we can talk and sort of lay out what the future looks like. One thing I will say is that in medical education over the last few years, there is a real shift to social accountability and social responsibility. And what that means is that increasingly medical educators and health professional educators are looking at the types of information, the types of learning, and the types of training to really equip the next generation of health professionals with the ability to respond to societal needs, so the health needs that are coming from individual patients, that are coming from diverse communities, underserved communities. And so really there seems to be a bit of a change happening in sort of what the past might have looked like hard science and all the kinds of things that you need to understand chemistry and biology of the body in order to practice in medicine. All of those things in the past were very much at the center of medical education. They still are, but there are also new things that are coming, which is the ability to communicate, the ability to be a collaborator, to be an advocate for health in your community and in the population you serve. So we're seeing the role of the physician shift a bit, and likewise, in order to make sure that those physicians are equipped to give the best care possible, medical education needs to shift with it. So without further ado, I would like to turn it over to Dr. Ford.
Thanks very much, Daniel. Thanks, everybody. I'm really thrilled to have the chance to talk to you tonight. What I'd like to do is tell you a little bit about a problem that I had teaching the med students at UBC and a solution that I came up with, and I'll let you know how it worked and if that solution led to any other problems on its own. As Daniel said, I teach the blood block for the second-year medical students. The first 2 years of the UBC medical school program are devoted to blocks of time for each system of the body. So there's a cardiovascular block and a respiratory block and a blood block, and blood gets 2 weeks because we're half as important as the stomach. And the UBC program was one of the first, I think was the first in the country to distribute its teaching across a wide geographic area. So we have, most of the students are in Vancouver here, but there's students in Victoria and Kelowna and Prince George as well. And those students sit in rooms like this, and they would see me on the screen with slides on the screen, getting the exact same material, the exact same time as everybody else. It's the distributed medical program at UBC, and it seems to work really well. It has a couple of problems. One of them that was brought to me by students a few years ago was after during the lecture, the students sit in seats like you're sitting in with microphones like you have. And if the students have a question, they put up their hands, and the instructor says, yes, would you like to ask your question? The student pushes the button on the microphone, and the camera zooms in on that student, and that student's face is then 40 feet wide on the screen. And that student says, Dr. Ford, I don't understand. What's the difference between ferritin and transferrin again? And then I explain it, and they go, okay, thank you, and we zoom back, and I go on with my lecture. Students hate doing that. I should say 95% of students hate doing that. 5% love doing it. Most of them hate it. And they don't want the attention. They think their question is stupid. They don't know that their question is shared by 50% of their peers. They just don't want to declare their ignorance, or maybe they can't really articulate their question very well, and they just don't feel comfortable doing that. So what happens is, after the lecture, you say, thanks very much, any questions? No? Okay, thanks. In 10 minutes, you're getting a lecture from Mr. Giustini on this and that, and we'll see you later. No. So what happens is, the students in Vancouver, if I'm lecturing in Vancouver, they rush the podium. The microphones are off at this point, but the cameras are still on. So the students in Kelowna and Victoria and Prince George can see the swarm down in Vancouver. They can't hear the questions being asked. They can't hear the answers I'm giving them. They just know that this swarm is going on, and they feel disenfranchised. And in a way, they are disenfranchised. They don't get that sort of face-to-face contact that the students in Vancouver do. Not all the lectures are from Vancouver. Some of them are from Prince George. Some of them are from Kelowna. But the problem is the same. The students at that site get the prof right afterwards to say, can you explain this little, I just didn't understand this little thing. Just tell me the difference between these two problems. They don't have that. So I would tell the students, well, email me your question, or I'll answer you right away. Or we had this discussion board in the password-protected UBC medical student faculty medicine website called Medicall. We had this discussion board for every block. So the blood block had a discussion board, and the students would put in questions like, can you please explain blah, blah, blah. And then we would write this 5-paragraph, 2-page answer about this is the explanation to your problem. And those worked well, but still I got these complaints. It's not fair that the students in Vancouver get to rush you and I don't. So what are we going to do about that? So we thought, well, we'll ban it. We'll say nobody can rush up and ask any questions. But that was a stupid idea, because then everybody suffers, and people still do it anyway. What do you, like, someone comes up and asks you a question, I'm not going to say, well, I can't speak to you now. You have to wait till you have a microphone in front of you. So at this time, this was a couple years ago, email is fine, but they don't want that. They don't want an email. They just want to ask you a question. They don't want to go to the trouble of email. I was using Twitter at the time just to follow people who write about the Canucks. Because it was really easy to do, and you'd get the trade stuff sooner than it was on TV, and I felt really like I was, an insider. I was on Twitter. And by the sounds of it, I don't have to explain Twitter is. If I gave this talk to the Department of Pathology, I'd have to explain what Twitter is, but my sense is the audience understands Twitter. So I was already on Twitter. I thought, well, I'll set up a Twitter account just for teaching. And it's really informal, and you can only ask 140 characters, so it can't be a complex question. It's perfect for dumb little questions. Define this word. I didn't hear you properly. What's the difference between A and B? If you ask me a complex question, I can't answer it on Twitter. But little questions, brief questions might work. And I don't give every lecture in my blog, but I go to every lecture, so I'm always there. And so the students can tweet me at any time, and I'm happy to answer during the lecture, after the lecture, at home in the evening, whatever. Let's see if that works. That was my solution to this problem of the students not being able to ask questions in the room. And it worked amazingly well, at least insofar as the feedback I got from the students was really, really positive. Most of the students knew I told them several times, I'm doing this Twitter thing. And so most of them absorbed that, and most of them at least followed, if not directly, they were sitting next to a friend who was following, so at least they read some of my answers. And probably about 20 or 30 students interacted with me quite a bit, asked me a lot of questions. And I just want to show you a few of the sorts of things that they asked me. So these are my own personal tweets. I wanted to go back and show you their tweets to me, but it's like 4 or 5 months ago, and it's hard to go back that far in Twitter. But I haven't tweeted that much since my course is over, so I can show you my tweets. I started out by saying that this was possibly teaching hematology in Twitter is the stupidest idea ever, but we'll see. And right away, I started to get questions from students. So this fellow asked me, why do you get damage to red blood cells in certain situations but not others? I got an email, or pardon me, a tweet from Dean here. This fellow here asked me just the kind of question that nobody is ever going to email a professor. We talk about peripheral blood in hematology. We talk about changes in the peripheral blood. And he said, well, why do you call it peripheral blood? Is there central blood? I said, no, we just always do call it peripheral blood. I don't know why. Everybody just does. And that interaction took me about 10 seconds. But nobody is going to email me and ask, why do we call it peripheral blood? No one is going to put their hand up in lecture and say, Dr. Ford, please, why do you call it? It's a sort of stupid micro question that can only be asked either face-to-face or some very informal place like Twitter. I've called it a place. It's not really a place, but it's sort of a place. I use Twitter to sort of give little messages about the block, like I'm coming to the Southern Medical Program, or I was just at the Southern Medical Program and we talked about this. And I not only responded to student questions directly on Twitter, but if I happened to get a lot of questions from a lecture I was at, then I would try to summarize that on Twitter later. Because if I happened to be in Kelowna and people asked me questions about macrocytic anemia, then I would take that chance to go on Twitter later and say, so, here's a little summary of this conversation I just had about this particular type of blood problem. And it happens a lot in teaching medical students that you find, teaching anybody, I'm sure this is true, that you find certain questions come up again and again. Everybody thinks they're the only one that doesn't know the answer to this question, but in fact, nobody knows the answer to this question. And so you hear the same thing again and again. And Twitter's a great way for me to tell everybody. I had this question from 15 different students today. Why does haptoglobin go down in hemolysis? Or just give little definitions. So I would sit in lectures, and a lecturer would show a slide with serum Fe and serum ferritin, and I would get a tweet during the lecture. Dr. Ford, are those the same thing? Is Fe an abbreviation for ferritin? No. Fe is iron. Ferritin is the iron storage protein. And probably in the course of the whole, I would get little questions about things like, is this lecture being recorded? Just little things like that. In the course of the whole block, I probably tweeted a couple of hundred times. And by the end of it, I was getting followed not only by the people in my class, but also by other students at UBC and their friends at other universities and residents who, you Google something and you follow a link and you find yourself on somebody's Twitter page and you sort of start following them for no particular reason. So I felt like it was interesting. I had this reach that was suddenly all of a sudden beyond my little group, my students. I'll tell you some of the ways that I thought this was successful and then maybe some of the possible problems that it might lead to. For me, it's solved the I can't rush the front of the room problem. At least it's solved it the best way we've been able to solve it till now. I'm sure there are students who feel quite rightly it's still better to look someone in the eye and say, can you please tell me the difference between macrocytic and microcytic anemia? But that's impossible in our program. The Kelowna students don't have that if I'm in Vancouver. But this gives them a chance to ask these quick little, maybe they think it's silly questions in a way that is not exposing them to what they would think of maybe as the ridicule of their classmates. They don't have to have the camera zoom in on them. They can just tweet me. And by its very nature, it's so informal that it invites silly little questions. You're not going to ask a complicated question about the epidemiology of a challenging illness on Twitter. It's impossible. But you're going to ask me, could you define this word, please? Or I didn't hear him right. Did he say that ferritin went up or down? Like, that's a perfect question for Twitter because it's informal. Another success for me was I found it didn't just solve the running down at the end of the class question. It solved I want to ask a question, but logging into Medicall is a pain. I got to go through 2 different login screens, and I forget his email address, and it's such a pain. This is just so easy. The students were tweeting me I had more questions, if you count Twitter, this past year than I did in any of the previous years. The number of students who emailed me questions or who put questions on the notice or on the discussion board just totally evaporated. They just stopped doing it. A couple did. Maybe they did have a complex question or they didn't want to use Twitter for some reason, but it went down like by 90%. Most of the questions I had were either in person or on Twitter. The students seemed to really like it. And I found it very useful. And I could go back and I could make sure that I mentioned that, or I would say in lecture, as I tried to explain on Twitter, blah, 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 let me talk about bleeding. It was a way for the students to go back and review questions that they'd maybe not asked themselves. And that's a nice thing that email doesn't provide. If you're a student and you email me a question, I only answer you. But if you tweet me a question and I put it on my Twitter feed, everybody can see it. And they can go back later when they're studying and go, oh, yeah, I actually had that question, but I didn't bother asking, and now I see it answered, and now it makes sense. There are some problems, maybe, with Twitter. I'm going to say I didn't sort of have any problems myself, but I can see potential problems. Number one, it's very informal. Twitter's very informal. So you might be inviting, excessive familiarity with students. It's a good thing for the educators to be close to their students in a lot of ways. But you're not their buddy. I'm not their buddy, right? I don't have to pass the exam. I've already passed the exam. And my fund of knowledge is much greater than theirs, at least in this topic. So I'm not exactly the same level as they are. And the informality of Twitter could maybe lead the professor to be a little casual about stuff, like you assume knowledge, you treat the students like they're your buddies. And you want to be friendly with them, but they're not your buddies. Part of the informality is problematic only insofar as I can only do 140 characters at a time. So it's not really informal, but it's very abbreviated. And a lot of the stuff I'm trying to teach is complicated. So a lot of the explanations I give are like 4, 5, 6 tweets long. And it's a little hard to do. It's a little awkward. You have to abbreviate things, and you have to kind of make assumptions about what they know. It's a bit challenging. Email, of course, you can write whatever you want. Discussion boards, you can give a 2-page answer. This was a little difficult, so it was a bit hard to explain certain things on Twitter. A problem that I didn't have, but that was raised to me after that, gosh, that could be a problem, is privacy. And I know it's something that I think Dean's going to talk about and we may talk about later. Medical students, if they're just asking me about a lecture, it's not a privacy issue. But not so much in second year, but by the time they get to third and fourth year, these students are taking care of real patients. And I had senior year students and residents ask me questions about their patients on Twitter. They didn't name them. They said, I had a girl with this bleeding disorder and then there was blood in her urine. Is the blood in the urine because of the bleeding disorder, or does it mean she have another problem as well? And I personally think there's no privacy problem with that. You're asking what amounts to a type of a hypothetical. As long as the disease you're describing is not incredibly rare, that someone who randomly came across your thing would go, oh my God, that's me. I'm the only person with factor 7 deficiency in the province. So if I see you talking about this, I know you're talking about me. If you're talking about things like bleeding disorders or patients with anemia, as long as there's no identifiers, for me that's like giving a public lecture about a bleeding disorder. It doesn't mean you're talking about a particular patient. But students might make a mistake. And students might say, my patient, Jason Ford, has this very rare and absurd complication of syphilis, and so let me tell you about it. And all of a sudden, the patient's name and the disease is out there on the internet, and that's a privacy violation. That could cause big problems. Didn't happen to me. I must say, when this question was raised afterwards, what are you going to do about this? Isn't this an issue for you? I thought, well, it's not really. We don't tell medical students that you're not allowed to speak to your colleagues about your patients. We say you're not allowed to speak in a public place where your patient's privacy could be compromised. We know medical students do talk about their cases with each other and with their faculty advisors, and they do so in a way that probably does violate confidentiality, or it would if the patient were there or if family members were there. But when two professionals talk about a case, it's accepted that that's okay. People said, well, yeah, but maybe we should do this. Maybe we should build a password-protected Twitter version inside Medicall so that only medical students and faculty could log in and see it, and then there would be no problems. And I said, yeah, but we don't build a separate elevator system for students knowing that they're going to talk about their cases in the elevator. We don't say, students take elevator A, everybody else take elevator B, and then there's no privacy problem. We say it's ridiculous. We just teach them you don't talk about your patients in the elevator. So then we talked about, well, we need sort of a policy for social media. And it turns out there already is a policy for social media. I was just an ignoramus, and I didn't know that. The problem with that is that policies are written like that to protect the faculty from lawsuits. They're not written to help the students. I would be stunned if you could find me more than 2 students in the entire Faculty of Medicine who had read the social media policy. What does that mean? Students don't do that. They don't read the instruction manuals. They don't read the policies. They just do what they do. So it's not enough to have a policy. In fact, it's not anything to have a policy. We have to teach them. If you're going to be using Twitter to communicate with me, please remember you can't use patient names. You can't use identifiers. And honestly, they don't want to make this mistake. A student would be catastrophically embarrassed, would feel terrible if he or she made a privacy violation on Twitter. They're not trying to do this. They would do it only by accident, and they really, really don't want to because they want to be cool. They want to be in the in club. They want to be physicians. They don't want to be Twitter idiots. So this privacy issue is something that we have to think about, and we have to teach students how not to make mistakes like that. But it never came up in my particular circumstance. I would find it hard to believe that it would come up. And yet, people make mistakes all the time. People make mistakes that you think, how could you do that? It was so obvious. I make mistakes that you think, oh my God, how could you do that? So everybody makes, it's going to happen sooner or later. There's going to be some Twitter feed somewhere, probably here, and someone's going to say, oh, my patient, Mr. Smith. Oh, and all of a sudden you realize, wait a second, there's a problem. It hasn't happened yet, and at least to me, and I don't think it's a real big issue. That's all I have. This was a big success for me. I intend to keep doing it. I don't know if you have any burning questions now. You could tweet me, or you could ask me, or we could wait until Dean's had his chance to talk to you as well. What do you prefer, Daniel?
I'd say let's wait, and then we'll just
perfect.
We'll have a conversation.
I'll sit down, and Dean can talk, and then we can talk about it after. Thanks, everybody. How do I make the theater version here, Daniel? Excellent. So thank you very much for that introduction. And thank you to Jason for that sharing his experience with Twitter. What I'm going to tell you is really, in some ways, diametrically opposed to what he's been talking about. This is a very theoretical presentation on social media. And I've been doing some literature reviews, and all of you have the product of that, hopefully in front of you. And so what seems to me to be particularly true about what Jason was saying was that there's a great deal of literature that is being published at the moment about social media policy and codes of conduct. And quite often it's viewed in a very binary fashion. So you use social media or you don't use it. And quite often with the don't use it, there's the fear around HIPAA violations in the United States, for example. So what seems to be missing, I think, from this discussion is a look at the theoretical literature on privacy, which I think can inform us and provide some sort of framework for going forward. And so I'm going to introduce some of that theoretical literature to you. So let's start with a question. What is social about social media? It's on the internet, it's a tool, but what is it that is inherent about social media that makes it social? And is the social aspect, the ability to communicate back and forth with other people, some of whom you know and some of whom may be new to you, is that why it's so exciting? A follow-up to that question might be, what is social about medical education as it currently is conceived? There's problem-based learning, there's evidence-based practices. Are those social kinds of things? Clearly, social learning is an international trend, and I think problem-based learning and the rise of its application in medicine is really caused by that trend. So it seems to me that social media and medical education are natural allies. It's the social aspect. But why is it so difficult to get people to try social media in medicine? Is it because they're too busy? Is it because they're concerned about some of the things that Jason talked about a little bit earlier? So let me go on. In this definition, social media is said to bring people together to talk and share. There's a great deal of learning that can happen when you talk and share with other people. Social media encourages discussion, feedback, comments, and information sharing. That's one of the things I do in my work as a librarian. I'm constantly sharing with people things that I see, things that I'm reading, things that I think they might be interested in. That's a very powerful kind of connection that I try to make in my work. So all the things that we want medical students and faculty to do. We want to get beyond this idea of one-way conversations, and we want to have two-way conversations. Right? So this idea of two-way conversations and exchanges is how this Web 2.0 and Medicine 2.0 has come to be. So social media tools enable the social. So if you would, turn to your neighbor and share what you think is the most important social aspect of social media. I'll give you a minute, and you can talk to your neighbor about what you think is the most social aspect of social media. Go. This looks like sound.
It's this guy.
For me, it is.
Does that help?
That's good. Okay. So, as we come back, please remember what your conversations were, and you can share some of those nuggets with us after the presentation. So why bother with social media? In medical education, does it make sense for all of us to learn about the ecosystem of the web? Should we appoint people, librarians, for example, who are going to be experts in this area, or do we all need to have some sort of knowledge about how the ecosystems work? So what seems obvious to me, 5 or 6 years into this international massive trend, is that there are a lot of blurred boundaries between the public and the private as we move forward in this age of social media. And the boundaries between the patient and the doctor are also starting to blur. So one of the benefits of using social media is social capital. This idea that you can shore up your capital among the people who are in your network so that the network becomes more useful. Salvatore in 2006 compared social capital to developing a network of relationships with other health providers. So it's important in team-based, problem-based medicine. So the question is not why social media, but why not? Social media has enormous potential to bring people together, to be social, and to learn things. And as physicians and patients work together, they both enjoy a sense of empowerment. And that's what we want as physicians. That's certainly what I always feel I do when I meet with patients and they need information to make decisions. And so there is, again, a natural alliance there. So empowerment or shared agency, I think, is critical when you examine the traditional doctor-patient relationship. The relationship is deeply personal and intimate, but it is also complicated by imbalances of power. Patients are the ones that take their clothes off. I mean, that's one. It's the most obvious one. And they don't always have access to information and expertise about their condition. This leaves the patient in a very vulnerable position. The word patient comes from the Latin to suffer, as patients have a limited ability to relieve their own problems. The physician is therefore viewed as the one with the power. So I think one of the things that we see about the use of social media is this democratization. We see its implications in the Middle East. We see its implications in relationships. There are pros and cons. Sometimes people use social media to nefarious ends. We've seen some suicides with teenagers. We've seen some bullying that happens. But I think that if we were to look at it in its full context, I think we'd say that it's bringing a lot of very good things to the world at the moment. So the idea around privacy and power dates back to ancient Greece and Hippocrates and the Hippocratic Oath. What I may see or hear in the course of treatment in regard to patients, which no one must spread abroad, I will keep to myself, holding such things as shameful to be spoken about. Privacy has been an important concern from the beginning, but it's not hard to see that excluding the patient and withholding information from him or her runs counter to what is happening today on the social web. You know, I mean, when
Google was announced in 1998, we started to see how patients went to the web and tried to find out about their own conditions, and they build up their dossier of information and take them to their doctors. So when you look at the literature, there are a number of really interesting frameworks and theories around privacy, which I think can really provide some sort of context for each of you as you think about how much social media is useful for yourself in your own work, as well as how it might be integrated into medicine. So Altman's 1975 theory of privacy, we see some interesting parallels to the idea of exercising individual agency. Altman says privacy is the selective control of access to the self, and that we reveal, each of us, what we want to reveal. He says privacy is a dynamic, dialectic process, and one where we regulate our relationships. To me, that speaks to control of the person. The idea that privacy is somehow controlled by external forces or controls on Facebook or what have you seems to contradict this. You don't have to reveal anything on social media websites if you don't want to. I mean, you can use it for the purposes that we've talked about earlier, for learning, for sharing, for communicating, but you don't have to reveal things that you don't want to. And you certainly don't have to expect that the privacy controls will prevent you from saying something that you shouldn't. That's something that you govern within yourself. So in a more recent vintage, in 2002, Petronio wrote about the privacy management theory. The idea is that relationships are managed by balancing privacy over on the far, I guess, your left. Privacy is about concealing information or withholding certain types of information from others. And disclosure over on the right and revealing information. So some people might see that as incompatible, but what you want to try to do is find that sweet spot between revealing things in terms of your interactions with others and concealing things or not telling people about certain things. So I think this particular theory does merge quite well within the context of the digital age. Again, I say to my students, I say, if you are able, try to find if I have over the 7,000 or 8,000 tweets that I've sent out, try to determine whether I've revealed whether I'm single or married. They can't do it because I haven't shared that kind of information in that particular space. So in the literature review, I did see that there was a systematic review done on the use of social media in medical education. And of the articles that were retrieved, 49% of those discuss breaches of professionalism as really important problems. User privacy by 32% of the articles, and information quality. I mean, one of the things that we need to do as librarians is we need to find ways of getting the best evidence and the best information into the hands of physicians so that they can make decisions. So information quality is critical. Other concerns mentioned, no time, a lack of time. This is something I also see in my own field. Librarians say that they don't have the kind of time that they need to get involved in social media. But I think that's a big mistake. I think this is absolutely essential in building some sort of digital presence on the web and in building some sense of digital identity. So I think Jason has mentioned that he uses mobiles, and of course he's tried Twitter. I do think that there is an awful lot expected of doctors in the 21st century. They are distracted, they have iPads and iPhones and other mobiles, and I do think that somewhere you have to draw the line. But I do think that if you're going to use the affordances of social media, that you do have some great opportunities there to build relationships and shore up your social capital. Just last week, online professionalism, patient and public relationships in the Annals of Internal Medicine. And the article talks about some of the challenges and recommendations associated with use of social media by physicians. And under managing your identity and professional image, rather than talking about that sort of optimization and finding a balance, the question here is maximize online privacy settings for personal profiles on social networking sites. This is very typical. This is symbolic and emblematic of the kinds of things that you see in terms of guidelines for physicians. Put that security in place. Make sure you put the walls in place so that people cannot contact you. Using social media in a professional manner. Understand that all posted content could be considered public and permanent. That's fine. It's true. But again, don't rely on the privacy settings to stop things from getting out. You have to self-moderate. Encourage online behavior of physicians, nurses, physician extenders, and office staff to mirror the standards of behavior maintained in the office. I think there's even a higher standard when you're on the web. You do not want to engage in unnecessary arguments. You want to be the kind of citizen that shares information and creates an opportunity for learning for other people. So, patients need to ask good questions. Doctor, I would like to see my medical records in regard to the period when my systolic ejection murmur was heard at the second right intercostal space. I'm sorry, sir, but I never show my patients their records because they lack the knowledge needed to properly interpret the information. This, I think, provides some insight into the traditional relationships between patients and physicians. I think things are changing. We haven't really talked about the electronic patient record. But I do think that the control of that information, the agency has always been on the part of the provider. And so we're seeing these trends internationally to share information and democratize that sharing. And I think this is also having an impact in medicine. So one of the things that we can talk about as we go forward is this idea of privacy management. Context collapse is something that is discussed in the theoretical literature, and it means that when you go onto Facebook, all of your friends and family are all part of the same audience that you're speaking to. Context collapse. You don't have any way to do fine gradations in terms of how you communicate. When you speak to each other, you're constantly making micro calculations about how you interact with other people. But in social media, that context collapses completely. So I think you need to be aware of that context collapse. All patients have a right to control their health information, and in particular, who sees it. Social media can be very risky in terms of transmitting personal information. And if you think about privacy in the past, it was locked away in print records, and it was very difficult for patients to actually see their personal health information. But now there is a movement, obviously, for patients to be able to see that. This moves us to the idea of privacy literacy. Refers to the skills we need to engage fully in the digital world without compromising personal information, which implies that individuals and organizations need a better grasp of privacy obligations and their importance in the digital landscape. So this is important enough in BC that the Office of Information and Privacy is going to have a conference in October here in Vancouver. So finally, some takeaways. The web is a highly social ecosystem, critical to lifelong learning. I think 21st century learning is also highly social, and we're seeing that in problem-based learning, the use of problem-based learning across medical education and in evidence-based practice. So medicine is social, but it also has very exacting requirements for privacy. But it's not that binary setup or model that we were talking about a little earlier. I think physicians should be able to learn about privacy and balancing the controls of privacy. That it shouldn't be left to a second person, a secretary, or a research associate. Everybody needs to have these skills for the digital world. So social media and privacy literacy are needed for the future of medical education. And I think that that's what I'd like to talk to you about after the presentation. So thank you very much.
Thanks, Dean and Jason. Questions? I have some, but I figure somebody has some better questions than I do. Yes?
My question is for Dr. Hall. When you're doing your Twitter, do you do a tweet chat? Is that how you're doing it? Are you doing a hashtag and then you all go together in the tweet chat?
No, that's a great question. No, oh, I've got the little wireless thing on, I think. In fact, I don't know that I'm sophisticated enough on Twitter to know how to do that. I usually made an effort to reply just on my Twitter feed to everybody, no matter whether someone asked me a direct question or they put up their hand and I thought this is a good question. I try to put it there for everybody. Sometimes I forgot and I ended up in a conversation with just one person. So, those of you who are even less sophisticated Twitter than I am, and I'm relatively unsophisticated, depending on how you write your tweet, it can go to everybody or just the person that talked to you. So I tried to always make sure it went to everybody, but I never used sort of tweet chatting. Is that helpful? Is that a useful thing?
It's very helpful. Yeah, I use it on healthcare, social media, Canada. It's HCSMCA. That's a hashtag, and we always meet on Wednesdays at 1 or Wednesdays at 10, something like that. And you always go under that hashtag and go into the tweet room where you tweet amongst yourselves, although everybody can see it.
Right.
But the other problem I found even with the Twitter chat is that you can get a lot of people chatting. You can get a lot of questions coming up, and it's difficult. In fact, I stopped using it because it was just so noisy.
My sense is, I didn't try that with the students this year. It wouldn't be as big of a problem because there's only about 300 students in your class at any one time, and probably no more than a quarter of them are really into the Twitter stuff. So that it wouldn't be that noisy. The problem that I had was a little different with the noise, and it wasn't really a problem, but I found that it was an issue a little bit as the block went on. It wasn't that at a given time there were too many people, but the questions were coming sort of at all times of the day and night. And one of the advantages of having this informal communication method is the students feel very invited to just ask you questions, whatever's on their mind. One of the downsides is they feel very invited to ask you questions, whatever's on their mind. And then you're kind of obliged to answer them. So it became, I won't say a burden, but it was a bit of a challenge to manage my time on it.
My question is for Dean. When did you first come across the term privacy literacy? I've never heard that before, and I really like it. I've heard of information literacy, digital literacy, computer literacy, but privacy literacy and how you're explaining where, we ultimately have the control of privacy, but that's never really the focus. Mm-hmm. So, yeah, thanks.
So one thing I will say is that Danielle and her colleague are both librarians, so we're in good company. And before I answer your question, one thing that I wanted to say is that the library here at St. Paul's Hospital Library is closing. And so this is not fully public. But I just want to make a point about this idea of information and media literacy, which is related to privacy literacy. And librarians are involved in teaching the skills so that you can navigate all the different types of information sources you need in your programs and in various professions. So the idea of privacy literacy, I think, is starting to come up because of some of these information spaces that we've been talking about tonight. That And I do think the issues are framed in such a way to scare physicians and medical students from actually trying these different tools out. And so the idea then is moving away from the codes of conduct, which exclude people from the use of the tools, to more of this idea of literacy and what are the skills, the knowledge, and behaviors that are required to use these tools successfully. Yeah.
It's for Dr. Ford, but I guess equally either. The role of linking medical students with patients. And so what I mean is there's, for example, a pediatric respirologist at Mass General that does a lot of work. He's an older guy, he sort of says that his kids taught him how to use Facebook, but he has a Facebook page or group, more or less a group, where he brings his patients, his asthmatic teenagers together. And the way he puts it, they reveal way more in those groups to one another than you could ever get in a one-on-one encounter clinically. And so actually they teach each other. He actually is taught a tremendous amount by them. So is there any opportunity for bringing medical students into that sort of dialogue or that space where perhaps they can offer their own experience or advice to your patients in medical pathology?
Yeah, that's a really interesting idea. Honestly, I'd never thought about it, but it would be a great idea. And you know, Daniel, at the beginning, you talked about social responsibility and social accountability and communication, and these are in the medical education lingo, the non-medical expert CanMeds roles that we want the medical students to become proficient in. That sounds like a great way to let medical students connect with patients and their families in a way that kind of equalizes the power disequilibrium that Dean alluded to. Because you're just on a computer and you're not in a room and no one's taking their clothes off and maybe there's 6 patients and 1 medical student, or you know, it's a little more equal. And in that sort of environment, the patient is the expert and the student is the student. So the power relationship is a bit flipped. It's a great idea. When I was a student, you know, 20 years ago, of course this didn't exist, and what they had to do was try to get a couple of patients in a room with a bunch of students, and you tried to chat, and that's fine. It's a little easier to do that on a computer maybe than face-to-face if you're not comfortable as a patient maybe talking to a bunch of students. The only downside I can see from that is, you know, when you said teenagers, I suddenly go, wait a minute, what are they telling about themselves to other teenagers and to students who, you know, are still learning how to communicate in a respectful way?
Well, that's just it. So, I mean, the example was, say, bronchodilators and impact on sex life or otherwise, right?
Yeah.
And so getting into things like that, well, obviously it's sensitive terrain for teenagers.
Yeah, which makes it even more important, you know, because otherwise there's no way that, well, I shouldn't say there's no way. I find it hard to believe that a teenage patient would just tell a medical student, this is my experience with bronchodilators and my sex life. I don't know, maybe teenagers are a little more open than when I was a teenager, but maybe not. But on the internet, you know, as they say, nobody knows that you're a dog. So they can get away with saying all sorts of stuff on the internet that they maybe wouldn't feel comfortable saying in person. Again, I still would feel a little uncomfortable about that possibility because, as Dean said, it's always permanent, you know, and so here's the teenage patient feeling super comfortable teaching the medical student all about, you know, sex life and bronchodilators, and then realizing a year later, wait a minute, you know, all my personal stories about my sex life are now out on the internet. So I said earlier about policies around social media are designed to protect the faculty, not help the students. You'd need a pretty careful social media policy to protect the faculty from the sort of inadvertent privacy violation that not really privacy violation, but privacy error, I suppose, that a patient might make, a particularly young patient. It's a great idea, it just makes me a little nervous when you're talking about pediatric patients. Super, I don't know, Dean, do you want to speak to that as well?
That's complete.
Good.
Other questions?
Yeah, I'm actually an HIV patient and I use social media, so I'm really keenly aware of the privacy issues. And I think the best use I've seen of any kind of social media has actually been in webinars, where you can have a webinar and you can put your hand up in the webinar and only the facilitator sees it, which is really helpful. And you can only write a certain amount, let's say in this little box, and it's sent. I actually use them for professional speaking. So I take professional speaking course, and then I can ask a question, and the whole thing is kept. It's about an hour long conversation we have, and then it's kept on their website, and you actually have to be a paying member to get into that website. Then you can actually see that whole conversation we've all had again, so it can actually be replayed, which is nice. That's a nice feature. But on something like Twitter, it could be really difficult if you get your patients looking at anything. And also on the thing that you were suggesting, I find sometimes when you were talking about the bronchodilator, I have no idea what that is. And that's the problem, because patients don't understand the medical terminology sometimes. So talking to patients can be difficult because people are used to using a certain terminology. I like Twitter a lot, but I don't know. I maybe know 2 other people in the HIV community who are actually on Twitter.
Yeah. The use of social media to teach is very different from the use of social media working with patients. The roles and the implications for the practitioner and for the patient are very different from those if it's an educator and a student. The idea of this webinar is a really important one to me. You talked a little bit, I think, earlier, Daniel, about the future of medical education in Canada, and the future of medical education at UBC is that they're gradually going to be moving away a little bit, not entirely, but a little bit from lectures and labs and doing a lot more stuff online. Simply because you've got so many students at so many places in the province, and it's just easier to do it like that. And the idea of having like an interactive webinar is super appealing to me. Mm-hmm. I'll have to look into how to do that. I'm really unsophisticated in a lot of this. I think most physicians are. You know, we don't work in this environment, and so it's just sort of something that you do as a hobby, and then all of a sudden you find that you're the only one using Twitter to teach, and you're identified as some sort of social media expert, even though you figured out how to log in and hashtag, and that's about it. Yeah, I don't know.
But I mean, one of the things that I liked about Jason's use of Twitter was that he was open to the possibilities. I mean, if you think about Facebook, I mean, more than 1/6 of the planet uses Facebook. And I mean, with respect to Twitter, I was so excited to see somebody on the faculty actually communicating that way. And one of the things that I think parallels, I've actually worked with pathologists before. One of the things that is parallel is that as a librarian, sometimes I'm the only professional person in my area, so I have to transcend my isolation. And I think that, you know, pathologists, hematopathologists are quite often dealing with slides and working hard sorts of hours, you know, using microscopes and whatnot. And so this is one way that those professional groups can interact even though they're not in the same vicinity. And I've spoken to Dr. Wes Schreiber about this, and actually we wrote something in one of the pathology journals about using social media in pathology, but it's still very early days. So, you know, I think we keep trying to get people to use the tools and do the sorts of things that we're doing tonight, having conversation.
Robin, did you have a question?
I think this is for Dean as well. While we're musing about all of this, I was thinking about the concept of privacy literacy, and I'm a health communicator, so I thought I had a fairly sophisticated viewpoint of privacy literacy, but it keeps changing.
Yeah.
So, you know, where I felt literate 3 or 4 years ago, I don't necessarily feel literate today. So, you know, I think it's something that needs to be something that's not fixed in time, or, I mean, just to add to that.
You know, it's wonderful you're here. Actually, one of my former students, Daniel Hooker, was part of the original group of people that was part of Evening Rounds, and I was very pleased to see that. And he's working in communication down in the United States, and we've had some conversations about privacy literacy. And I think that if you frame it in those terms, it's not there's not this sense of blocking things off, but actually using the tools in such a way that you can continue to communicate. But as I said in my presentation, that you're concealing certain things that you wouldn't want anybody to know about, or you wouldn't want it to get out. So I do think that the idea of privacy literacy is starting to be used in like if you typed it into Google, you would find things, but somebody needs to write something. So send me an email.
I'm really sorry to cut short my own participation, but my 13-year-old is babysitting my twin 4-year-olds, and I'm worried that may not be going well. So I said I was going to be home by about 7:30, so I'm afraid I have to leave. I really want to thank you for having me, and thank everybody. Thank Daniel for inviting me. Thanks, everybody.
Further questions?
Yeah, I've got a question about, you put something up, Pew, P-E-W?
PEW,
Yeah.
The Pew Internet reports.
Okay.
In the United States, they look at the use of various internet technologies and report. I mean, you can just type Pew Internet into Google and you'll be able to find any number of different things. And the one that caught my eye was the privacy management, this idea of privacy management, because it's sort of on the topic tonight. One thing I didn't say at the beginning of my presentation was that I'm not an expert in this, and I had actually said to Daniel that I didn't really want it to be filmed because I'm still trying to work through some of the issues myself. It's just all new to me, and I do think that privacy is one of the major barriers and inhibiting factors for a lot of us. And, at the moment, it's almost like I've started to move into a mode of using Twitter just to send out good things, information that people might, want to use. But I can see that it also has an enormous potential for advocacy. And, for example, the McGill Medical Library is slated to close in July of this year. McGill's main medical library. And, it's hit the national news, but the St. Paul's Hospital Library and the Hamburg Library at BC Children's and Women's are closing in less than 2 weeks, and no one knows. And I really want to send that message out, but I also fear a certain release of information that really is not mine to release, right? So that's another issue. But something stopped me, and really it's not my information to share, so I'm not going to share it, because it's certainly not public yet. But it will be.
I was wondering about if you had seen anything on like defamation, like peer-to-peer conversations and...
Definitions, did you say?
Defamation, like defamation of character and things like that.
It's huge.
Yeah.
I've been blogging since 2004, which is prehistoric, really, when you consider, it's 2013. And one of the things I remember very early on was watching to see, there was one post I did on copyright and the difference between the United States and Canada. And one of the things I was watching for was the discussion in the comments. That when somebody leaves a comment on your blog, if it's defaming somebody else or if it's saying something negative about somebody else, you can be liable, right? So defamation is going to be a big problem. We're already starting to see the lawsuits starting up. It's very easy to assume a pseudonym and then take somebody on, but you can, trace the person. So again, that's about digital citizenship and being a good digital citizen and making sure that, that you treat the tools that we have available to us for the best possible purposes. And, there are a lot of trolls on the internet and people, trying to take other people down. I mean, get something positive happening in your life.
Any further thoughts or questions? No? I have a bit of housekeeping here I'd like to share with you guys. So the next Evening Rounds, Volume 8, is on May 21st. It's here in this room. And we would like to thank everyone who took time to fill out the survey last month. And in fact, the results from the survey have helped us to define future directions and how we can serve the group better. And we are listening to what you tell us. So many people asked or inquired about wanting to learn more about how to measure digital campaigns. And so the next evening rounds in May will cover tools and evaluation methods. The topic is measuring success, tools and strategies for measuring digital communications, and interpreting results for internal buy-in. And speakers will be coming to us from our own team. So Julia Weiss, a digital strategist, and Janelle Chung from Signals Design Group, as well as In Rowe, who is the content strategist at the BC Center for Disease Control. So I'd just like to thank everyone for coming out tonight and for your questions, and to our presenters, Dean and Jason. Thanks.